from ODM on who can be a paid caregiver. We will also discuss the new rate increases that are also to be effective in January. Please make sure to put all your questions into the chat so we can answer them as we go along. The training is recorded, and we will share it just with the PAA staff. So if you do not want your face shown, please keep your camera off. And we're ready to go. So next slide, please. Okay, the first rule we're going to review is 5160-4411. The full meal rule has been rescinded and they have replaced it with a new rule. We'll just go over the changes that will impact us. So the new rule defines the difference between a standard kosher and a therapeutic meal. It completely eliminates the term special diet. So what we need to look for is the standard meal means a meal that adheres to the version of the dietary guidelines for Americans in effect on the delivery day and at least 33% of the individual's diet reference intakes. A standard meal may include, but is not limited to, a reduced calorie meal, reduced sodium meal, reduced sugar meal, gluten-free meal, or vegetarian meal if the individual chooses the meal by personal preference. They've also added in a more extensive kosher meal definition, which is that it complies with the kosher practices for meal preparation and dietary restrictions and certified as kosher by a recognized kosher certification or kosher establishment under Orthodox rabbinic supervision. And so this language means that an individual can choose to have any of these standard meals if that's their preference. Next slide, please. So they've changed it from therapeutic diet to therapeutic meal. And this meal is provided in accordance with an order by a licensed healthcare professional whose scope of practice includes ordering therapeutic meals for management of a disease or clinical conditions, to modify, eliminate, decrease, or increase certain substances in the diet, or to provide mechanically altered food when indicated. It does not specify what type of healthcare professional. This could be a licensed dietitian, a licensed speech therapist, as long as the nutritional and therapeutic diets are within their scope of practice. This rule has removed deeming language, and you will see that several times throughout the presentation, because the deeming language has been removed from all these rules. And I'll pause here for any questions. No. Okay.
So far. Oh, sorry, there is a question. Do the kosher meals need to meet the standard meal requirements?
That's a good question. It doesn't specify that in the rule. So we'll have to get back to you on that. Okay. Next slide. Tell us more.
We might have to take some of these questions back because they are ODM rule updates. Yes. So we do have a running FAQ. I know the oversight training is the first training of the week, and the assisted living provider oversight training is tomorrow. Clinical is coming up this week. We're kind of kicking it off. So any questions that we're getting from this that we can't answer, we're going to take back to the team, and then we'll make sure to get you guys an FAQ from this meeting. So we'll look into that one as well to kind of see what the expectations are.
Yeah, there's no, that's literally all it says in the rule, so we'll have to get further clarification. Okay. All right, so this one is for home maintenance and chore, 5160-4412. This rule was amended. So the new portion is that it is allowed, added allowable services under this program to include the removal of environmental hazards and upkeep and maintenance of home modification or adaptive assistance devices. For environmental hazards, that includes non-routine disposal of garbage and or other accumulated items in an individual residence, non-routine yard maintenance, including snow removal, pest control and related tasks to suppress, eradicate, or remove pests and mold eradication. And for the upkeep of home modification or adaptive devices, this is routine maintenance plan, extended warranty, service call, labor and parts for modification or device that ceases to function as intended. They have added a requirement for provider record retention, proof of appropriate qualifications to perform services requiring specialized skills, proof of licensure, and proof of all necessary post-inspection reports. Items that were removed were the allowance for the service to be accessed 180 days prior to an individual's transition from an institutional setting into the community, and part of the reimbursement any and only be adjusted if the fixed cost proposal is adjusted pursuant to the requirement set forth in E3B of this rule. Next slide. They removed the requirement to obtain final written approval from the individual and the case manager after completion of the service. They've added that home maintenance and chore may only be provided by an agency or non-agency provider approved by ODM or certified by ODA as a Medicaid waiver provider of home maintenance and chore. They've also added that the authorization of home maintenance and chore may be combined with other waiver services to meet assessed needs of the individuals. In such instances, individual waiver service limits as described in paragraph C of this rule still apply. And C is simply that there's a $10,000 limit on this service per calendar year. And again, the deeming language has been removed from this rule as well. Any questions? Next slide. All right, and this is 5160-4416 for the emergency response system rule. This rule was just amended. The removal of the notification being sent to the station if the battery level is low. What it now reads is that the unit requires an internal battery life of 24 hours. And again, deeming language removed. Any questions on this one? Okay, next slide, please.
Sorry, there is a quick question.
Oh,
just in
sure.
general, asked, will this PowerPoint be provided to us? Yes. We are recording the PowerPoint as well.
Yes. Next is 5160-4413 for the home modification. This rule was rewritten and reordered, so there's not a lot of changes. This rule has a new similar statement to the home maintenance and chores, and that the authorization of home modification services may be bundled with other waiver services to meet the assessed need of the individual. In such instances, the individual waiver service limits as described in paragraph A of this rule still apply. And again, A is that same $10,000 per calendar year limit. And again, deeming language was removed. Any questions on that one? No. Okay, next slide. And this one is 5160-4414 for community integration. And this one was amended. Again, removed the deeming language, and they decreased the years of employment experience required providing community-based social services or job coaching from 3 years to 2 years. Any questions on that one? Okay. Heather will take over for the next session. Thanks.
Okay. So I will start with waiver nursing. So just a quick overview, as I'm sure most of you know, this rule outlines the service description, limitations, provider qualifications, provider requirements, and then the clinical record keeping requirements for this waiver nursing service. So this rule 5160-4422 was amended, or it will be as of January 1st. So a couple changes, not too many, but this rule has been reinstated. The limitation that prohibits the use of waiver nursing services from being used as a substitute for similar services, which may be available through third-party insurers, community supports, other resources available. So you'll see here added B1, which describes the reinstatement of that limitation. Next slide, please. Okay, so oops, let me go here. So probably the biggest change this rule is that the rule is amended to now permit spouses and relatives to serve as the direct care worker for this service. So I want to make a note that this change only applies to nurses employed through an agency, not non-agency RNs or LPNs. So added is the C1A, parent of a minor child, spouses and relatives with appointed legal decision-making authority may serve as the direct care worker in accordance with the new rule, which Angela will go over in a little bit, 5160-4432. And she'll go over the requirements because any spouse or parent of minor child, relatives, etc., will need to meet certain stipulations to provide the service. Next slide, please. Okay. So with this one, another amendment, so the rule will allow for required visits from RNs and LPNs to evaluate the services be conducted via telehealth, and that those assessments will need to be billed using state plan nursing assessment code. So kind of breaking it down, we'll see E1. So E1 and E2 applies to non-agency LPNs providing service at the direction of an RN. So originally E1, you need to conduct a face-to-face visit with the directing RN at least every 60 days. Now it just says conduct a visit with the directing RN at least every 60 days, and that this may be conducted via telehealth. And then E2, they removed face-to-face. So now it's just conducting an in-person visit with the individual and the directing RN at least every 120 days. And then new is E3, which is when the RN performs the assessment visit, this will need to be billed with the state plan nursing assessment code. So this is now required for the RNs doing this assessment. Next slide, please. Okay, so what things were removed? So H was removed, which is the face-to-face visits required by this rule may be conducted by telephone or electronically. So a rule now specifies how this one needs to be done. And then of course, the deeming language. Okay, and are there any questions before I move on for waiver nursing?
We did get one question in the chat. This relates back to the home mod and home maintenance requirements. Is the $10,000 threshold per service. For example, an individual could have $10,000 threshold for home modification and a separate $10,000 threshold for home maintenance and chore. I believe the answer is yes to that. They are separate services. So no other questions about waiver nursing.
Okay, all right, we'll go ahead and move on. Next slide, please. Okay, so community transition, which is 5160-4426. This rule will be amended as of 1/1. So basically, the rule has been expanded, the allowable basic household expenses. So some of these aren't necessarily new, but they have been expanded. So let me go here. Okay, so in the first section here, the expenses necessary to enable an individual to establish a basic household. So it goes through the examples just like it previously was, but again, there's a couple new ones that are added and then primarily expanded. So security deposits, rental fees needed to obtain a lease on an apartment or a home, and any rental expenses required to obtain a residential lease. Essential household items such as furnishings, moving expenses required to occupy and use a community home, which could be furniture to maintain housing, window coverings, food prep items, linens, setup fees for direct deposit for utility and service access, including telephone, electricity, gas, garbage, water. Next slide. So continuing on. services necessary for the individual's health and safety, such as pest eradication and one-time cleaning prior to the occupancy. The same as before, pre-transition transportation necessary to secure housing and benefits, initial cleaning, household supplies, activities to arrange for and to procure other non-recurring setup expenses, the same as before, and then newly added essential personal hygiene and clothing items needed to transition safely. So those have been expanded and added to. Next slide, please. So what has been removed in this rule and community transition? So removed is F6, which is the flexibility to allow a signature to be obtained at a later date. So it just says it needs to be obtained during that the service was verified. And then of course, G, the deeming language was removed as well. And next slide, please. Okay, so new under B. So this is what community transition does not include. So what they added was 7. That's the only addition. So furnishing living arrangements that are owned or leased by a waiver provider where the provision of these items and services are inherent to the service they are already providing. So an example for this would be if a service should already be providing these type of items, then the community transition service would not also be providing these same items. So we see this with assisted living. So again, CMS issued guidance, which prohibits the community transition service provider to pay for items that the assisted living facility should already providing. So that means the list of items which are outlined here, you'll see in 3701-16-15 should already be provided by the assisted living. So some examples of these items could be bed linen, blankets, pillows, bedside table, trash can, towel, shower curtains, hanging devices, basic toiletry items, and paper products. And just kind of some information about basic toiletry items, that would be toilet paper, paper towels, soap, toothbrush, toothpaste, comb, hairbrush, and you can check the resident agreement for additional details of each facility. But that's just an example of what would already be inherently provided by assisted living that community transition would not also provide to that individual. And just so what we have here is that if you come about an individual where the assisted living is not providing those items, you can notify ODH that they are not doing that via the phone number or the complaint form here. Case managers and clinical teams will probably primarily be the folks who are more aware of individuals not receiving these items, but we wanted to make it aware for all of you here too, if you become known that they are not providing these items to people. Hopefully that makes sense. Any questions on community transition? I do see one. Let's see. Did you say the signature of receipt can no longer be obtained after the fact? Yes. So it cannot be obtained at a later date. So how will that work in real time? That's probably something we'll want to discuss a bit further before we give guidance today. And we will put that on our FAQ for all of you. Any further questions on this rule before we move on to the big one? Okay, well, I will go ahead and turn it over to Angela, and she's going to talk about the new rule we've all been long awaiting. And I will turn it over to you. Thanks.
Thanks, Heather. So I think that you guys can share in the excitement of this new rule, since this is a brand new rule that ODM put in place. This was after many meetings and many months of kind of processing how this would work as a state. But we want to kind of go over this rule in a little more detail with you. I want to preface all of this by saying that the majority of any of the compliance with this rule is going to fall on the clinical and the case, like clinical team and the case managers. So we're going to go over like a high level overview of the rule, but we're also going to go over the clinical process that's going to be gone over with all the case managers later on this week. But that way you guys know the process and kind of how it's going to flow on the case management side, and then what the providers will get from the case managers, things like that. But it's not going to change a whole lot for you guys for overseeing the providers. So This is the new rule, 5160-4432. The name of this rule is Home and Community-Based Medicaid Waiver Program Provider and Direct Care Worker Relationships. We did put a link to the rule in here. That way, if you guys have not already done so, you can go and read the rule in detail. So just some basic knowledge about this rule. It does go into effect on January 1st, 2024. This Medicaid rule applies to ODM, ODA, and DODD waivers. Again, if you haven't already, please go read the rule. And then we also put a link to the extraordinary care instrument in here. There was an overview that Medicaid did. So we put the registration link in here if you want to look at that. That is going to be a tool that the case managers will use. We'll kind of talk about it later on in the presentation. There is going to be a training released from Medicaid about 5160-4432. It has not been released yet. The goal was to put the link in here, but since it hasn't been released, we will get that over to you guys as soon as we get access to it. So just a few definitions. We kind of pulled some of these from the rule. We're not going to go over all of them, but I just think that maybe they're important for everyone to understand. That way, when we are talking about the rule, you guys can understand kind of the relationships and things like that. So when we talk about individual, that's obviously the consumer that is going to be receiving the passport services. Legal representative, that's the person who has any legal standings to make decisions on behalf of another person. So this could be like a court-appointed guardian or someone that has been granted power of attorney over the consumer. When we talk about parent for this rule, it is defined as the adoptive, biological, or step parent. We know that parent isn't going to apply to many individuals on passport, but we just want you guys to know that parents can become the paid caregivers. Relative, when it's defined in this rule, is talking about children, grandparents, grandchildren, great-grandparents, great-grandchildren, brothers, sisters, aunts and uncles, nephews and nieces, any kind of step relations, and parents of the consumer above 17. Any other relation, this rule is not going to apply, and then they would just be the regular paid worker that they've been prior to when the public health emergency went into place. And extraordinary care. Again, this is an assessment tool that the case managers are going to complete with the consumer and the individual that they want to be their paid worker. But it is defined as hands-on assistance with the activities of daily living, incidental activities of daily living, and supervisory monitoring care that would exceed the range of activities that a family member would ordinarily perform in the household on behalf of that consumer without a disability or chronic illness of the same age, or on behalf of the spouse without a disability or chronic illness, referring to the extraordinary care tool, again, completed by the case manager. But you'll just hear some of those terms throughout this training, and you'll hear them throughout the rule as well. Okay, so if there is a request for a spouse or a relative with that legal representation designation to be that direct care worker for the individual, then an assessment shall be completed by the case manager. That case manager is going to determine if the requirements within this rule can be met, and they're going to determine if that spouse or relative with that legal representative designation can or cannot become that direct worker for the individual. So the rule applies to these various services. So homemaker services through an agency, personal care services through an agency or participant directed, waiver nursing through an agency, and choices home care attendant through participant directed. Throughout this rule, we're going to talk about two different relationship categories. So there's the parent of a minor child, which again, because this rule applies to DODD and ODM, that's going to be referenced a lot, but it can also be a parent of somebody on passport as well. So parent of a minor child or spouse of the individual, and then any relative of the individual above the age of 17 that holds that legal designation over the consumer. So the first category we're going to talk about is going to be the spouse of the individual. So with this, the spouse of the individual may only provide HCBS waiver services to an individual if both of these conditions are met. Again, the case manager is going to make sure that these conditions are met, like before even moving forward in this process. So the first one is that there's no other willing and able-bodied provider that can provide this service. And then the other one is that ODM, ODA, DODD, or their designee has determined that the health and safety needs of the individual can be ensured by that person providing these services. So the next part of this rule was E2. So when those conditions are set forth in E1, so when it's present, the spouse of the individual can serve as the direct care worker within the following parameters. So there are a few limitations. They have to be employed through an agency or provide an eligible participant directed service through that financial management system. And unless otherwise permitted by the HCBS waiver rules or determined by ODM, ODA, or DODD, or the designee as necessary to ensure any health and safety of that individual, the maximum amount allowed of hours is going to be 40. What I do want you guys to know is that ODA has developed an operational process to allow for up to 56 hours. Again, managed completely by the case manager, and you guys are just going to see this reflected in the service plan that is sent over to the provider. So just know that under normal conditions, it would be a maximum of 40 hours, but we are going to allow up to 56.
Hi, Angela. We have one question.
Okay.
What qualifications would these family members require, such as are they required to complete home health aide training?
They would get hired by an agency just like any other personal care aide, or they would have to enroll in like participant directed. So they would follow the same process that anybody else would. So again, that, you know, that could be certain qualifications that providers might make part of their qualifications for hiring. So the case manager is going to go over all of this with the individual and their paid caregiver. So they're going to work with the paid caregivers to assist them to, you know, get hired at an agency and kind of follow through with that, or if they want to work through that participant directed program.
We do have one additional question before we move on. So will provider relations monitor the family member's file at the provider's site?
We've talked about this, and if you guys happen to pull that employee's file, because again, you just have to do the percentage of the employee files when you're going out and doing your structural compliance review. If you do pull it, you would look at it just as any other employee. There's nothing specific that's going to be in this file that you wouldn't see in any other employee's file. Where, and we'll talk about it a little bit later, but you're going to see certain things in the service plan and the care plan that should be in the consumer file.
I'm sorry, can I interrupt for a minute, Angela?
Yeah.
Hi there. I just want to say the 56 hours is already an existing rule, so that's not a change for anybody as far as the maximum that any one person can work. So I just wanted to say that and just pop it in there. But yeah, the clinical side, when we have our discussion on Thursday, we will go into detail as far as what the clinical folks are going to do to ensure that this is all being met. So in any event, you know, you're all welcome to see that too. And as with this presentation, it's going to be recorded and then PowerPoints will be sent out afterwards. So I'm sorry to interrupt, but I just wanted to pop in there with a little plug for that regarding self-direction. Thank you.
Thanks, Alicia.
And one other question.
Yeah.
Okay, so with choices and the financial management system, if the spouse is determined eligible to be the provider and is the legally responsible family member, would there need to be a different person to be at the PPLAR if the participant cannot self-direct and needs the AR? Oftentimes the spouse is the AR authorized rep.
Correct me if I'm wrong, Alicia, but that's yes. They can't be the person that's signing off on services as well as the direct paid worker.
Absolutely. Just with this addition, but it is the same because it's still the same principle that you can't have a person signing off on their own timesheet as a provider and as the oversight. So you are correct. Thank you.
So with E2, case managers are going to oversee the following. This is all just an FYI for you guys. That way you kind of understand the case management process. So the case managers, if this only relates to the spouse, if the spouse is determined to meet the extraordinary care requirements as determined through the 10372 form, that's actually the Ohio Extraordinary Care Instrument, this will be completed with the individual and the spouse. And the individual agrees to cooperate with monthly case management agency or services and supports administrator contacts. So the case managers are going to be, this is going to be an increased contact schedule for them. It can be a combination of telephonic or in-person visits, but there can't be any longer than 60 days between those in-person visits. And the spouses must participate in contact and visit requirements described in the individual's person-centered plan. And a spouse, this is kind of what we talked about, a spouse appointed as a legal guardian must show evidence of the guardian's ability to be the direct care worker for the individual. And I know somewhere we mentioned in here at some point that, just like Alicia and I said, they can't be the same person that is the authorized rep and signing off on their own services. Any questions about spouses before we move on to the next category within the rule? Okay, if any of them do come up, just pop them in the chat and we'll get to them.
One came up.
Yep.
The extraordinary tool does not need to be completed for parents or step parents.
Correct. That's spouses only. So now we're going to kind of talk about like those parents and step parents. So they fall into the relatives with legal representative designation. So as a parent of an individual above the age of 17 years old, they may provide services described in paragraph A of this rule while holding these legal designations. So they can be the authorized rep, declaration for mental health treatment, general power of attorney, the healthcare medical power of attorney, representative payee, or guardian appointed by the probate court. So those are the legal designations that they are able to hold and be the direct paid worker.
We got one question in, but it's for Alicia. Will the cost cap be addressed in the clinical training?
It's not, but in actuality, as we said, there was another question before about like the $10,000 allocation towards different services and things. And as some of you may know, in Ohio Home Care Waiver, they have different pots of money for those type of things. Like they are not finite pots of money. And Passport, some of them are, but remember our cost cap is $14,700 per month. So generally, if there's something that exceeds something or anything like that, we can talk about it. But just the fact that the cost cap has been raised so high over the last few years in our work with alignment, cost cap doesn't come up too much. But we certainly can talk about it during the clinical training as questions pop up. But thank you, because that is important. I can't imagine anybody would meet the cost cap in self-direction simply because, unless they had multiple workers, simply because, 40 hours is a max that any one person could work. So you'd have to have like 3 providers, and the fact that the highest wage, even though it's been raised, still, I don't think you could meet that 14.7. So I don't think it's even possible, but thanks for bringing it up and we can talk about it. But I'm still here, I'm listening. So if you guys have anything else, let me know. Thanks.
So then F2 goes into those other family members. So the adult children, grandparents, grandchildren, great-grandparents, great-grandchildren, brothers, sisters, aunts, uncles, nephews, and nieces, and any step relations, they can hold the same designation. So the authorized rep, declaration for mental health treatment, general power of attorney, healthcare, that medical power of attorney, or guardianship.
Another question?
Yeah.
Related to the last one. Didn't they just say the provider could work up to 56 hours?
Yeah, so this is it's the same for the family member and the spouse, where in 160-4432, it has the limit of the 40 hours. But just like it says, if ODM, ODA, or DOD comes up with their own process, our internal process is the allowable for the 56 hours.
So, hey, Angela, Sarah. So the rule says that there's a limit to 40 hours, but within the rule, it also allows for an exception process. So the 56 hours is this exception based on a specific set of circumstances. So it's not that you can automatically get 56 hours. It's if there is a need for up to 56 hours by the single provider, an exception can be made, if that helps make it clearer.
Right. And that's been in place for a while too. This is just kind of finalizing that sort of thing. And again, allowing the few people that before weren't allowed to be paid. So the other thing is too, is we always talk about 40 hours related to self-direction. And a lot of people throw that around, and it's like not many people get 40 hours. So that's something else to think about. You're not automatically approved for 40 hours just because, that's something too that people throw around with us. And it's like, oh, it's based on client need, which is what we do anyhow on the clinical side when they're assessed. So, and a lot of this will go on behind the scenes. It doesn't affect like you're in like the provider enrollment process. So, all of these things are applied to the provider once they are actually a provider, an active provider or an appropriate provider for any of these services. So just like they do now. So there's a lot of things that go on to make sure it's okay, including this extraordinary care tool and these hours and the maximum of 40 with the potential of 56. So I know that's a lot right now, and I don't want to take over their training, but that's basically kind of the background on that. So don't overthink it right now. Just, and definitely if you want to sit in on Thursdays, we can go over things on the Thursday call. We can go over it too. So thank you.
We have one more question. Will the threshold for service plan review, which is 60% of nursing facility costs, be raised with the increase in rates?
We'll have to take that one back because we are going to talk about rates today, but I don't think we've talked about that part of them yet. So we'll take that one back. We'll get that in the FAQ. But going back to these hours, I just want to say case managers are going to complete the process, and they're going to do their tools. They're going to do everything. And like Sarah said, they're going to manage if there is an exception to that 40 hours. So this is, again, kind of like an FYI to you guys for the provider oversight side of things. And case managers are going to take care of a lot of this. So the next thing we're going to talk about are spouses and relatives with legal representative designation. We're going to kind of talk about like some limitations within the rule. So some limitations are, unless otherwise permitted in other HCBS waiver programs, an agency fully or partially owned by the individual's legal representative is not eligible to bill for Medicaid reimbursable waiver services to an individual for whom they serve as the legal representative. So if somebody's daughter or son is partial owner of an agency, they're not able to bill through that agency. Some other limitations are the direct care worker providing services described in paragraph A may not verify service provisions on behalf of the individual. So that was addressed in the rule. So if they hold that legal designation or they're the authorized rep, they can't sign off on their own time cards or like through EVV or anything like that. So somebody else would have to do that for them. So a direct care worker may not receive payment from any other source for activity other than the direct care for the individual during the time authorized to provide the HCBS waiver services. The direct care worker may not provide care to a person other than the authorized individual or individuals during the Medicaid billed hours. And for participant-directed services, if an individual chooses to designate a representative through that financial management system, the financial management system designated representatives may not serve as that direct care worker. So any questions about any limitations when it comes to spouses or relatives with that legal designation? Okay. So we kind of wanted, again, go over that high level overview of the case manager process. So when that request comes in, the case manager is going to complete an assessment. They're going to complete it with the spouse or the individual or the relative that holds that legal designation. They're going to figure out if they meet qualifications through this rule to even move on in the process. And if they are a spouse, they're going to complete that extraordinary care instrument. They're going to then assist the family members or the spouse with either going through the participant directed program or get hired on through an agency. They are going to have to put a care plan line in the care plan. So that they put an example of what that would look like, just that way you guys are aware. So within that consumer file, you should see a copy of the care plan and the service plan. So the expectations within the service plan is in that comment section below the hours. They're going to list the direct care worker's name and relationship to the individual, including that legal designation that they hold, and the number of hours that they are authorized to provide to the individual. So really, that's all you guys need to know is what to look for in the care plan and the service plan. And if you don't see it, just ask the provider to reach out to the case manager and make sure that that's in there. Are there any questions about 5160, 4432 at all? Because if not, Heather's going to take over and wrap us up for rate changes. Well, if you guys think of anything, feel free, pop it in the chat. If we can't answer it today, we'll definitely add it to the FAQ. But at this point, I'm going to turn it over to Heather, who is going to do the last part of the presentation.
Okay, rate changes. So of course, along with everything else, the rates are changing 1/1 pending CMS approval, of course. Next slide. So for passport services, so 5160 106.1 sets forth the covered services and maximum allowable rates. The rule is amended to include an increase to the maximum allowable reimbursement for services resulting from House Bill 33. So here are the following services that are impacted that'll get the increase. So adult day, community integration, home care attendant, homemaker, waiver nursing, Choices home care attendant, enhanced community living, home delivered meals, and personal care. So a lot of services are getting increases, which is great. Next slide, please. So here is just a capture of the upcoming increased rates for the services mentioned earlier. We won't focus on this too much because once we receive the CMS approval, we will send out an updated rate sheet to all of you to have. Next slide, please. Okay, so assisted living rate changes. So this rule is 5160 106.5, and this rule is amended to include an increase of the maximum allowable reimbursement, of course, as a result of House Bill 33. So they are updating the tier information in Appendix A. So we're going to give you just kind of a snapshot right now, but Meredith will go into much more detail on her training, I believe, tomorrow. So tiers 1 and 2 will be collapsed into the same per diem rates. And the former tier 3 will now represent a new memory care assisted living service tier for those individuals that need that additional support, especially as it relates to that higher personnel cost for supportive individuals with a form of dementia. So again, we will now have 2 tiers, basic and memory care. Next slide, please. So here is a snapshot of the assisted living tier and their rates. Like I said, tomorrow Meredith will be doing the training on this from 11 to 12. So she's going to talk about the new memory care service rule, the PIMS updates for the contracts, monitoring oversight for this rule beginning in January of 2024, and answer any questions. So we just wanted to give like a really high level view of the fact that these tiers will be changing. Next slide, please. So just a couple of things left for rates. So there's no need for the contracts or provider agreements to be updated because the rates are no longer in the contract specified in the contract. So we don't have to update those. As I mentioned before, there's not final approval from CMS, but we do anticipate the final approval sometime this month, hopefully before 1/1. And once we have that final approval, like I said, the rates will be shared with everyone via notice and get that updated rate sheet out to you all. So that's about it for rates. And I think that's our last slide. And then we can move on to just any final questions about rates, about the new rule, or any of the 5160 rules we went over. Okay, and I do see a question, so I'll go ahead and just put that one out there. So is there any action that needs to be taken on spouses who were initiated as paid caregiver under the PHE exception?
So the case managers they're going to be given direction. And Alicia, if you want to answer this one.
Sure. Yeah.
I saw you pop on.
I know. And I'm sorry. On our Thursday call, Lauren has lots of slides about this particular rule and how to work it. So, she will explain the process. And again, you will have, the first half of our training is going to be basically what Angela and her team has done, Erica and Heather. And then, so we're just going to kind of mirror it and do the clinical perspective. And so that way that you guys can have both or either. It's, for different audiences. And then the second half actually is really Lauren going into great detail about what is needed, what the steps are, and that sort of thing, so that everyone can know what's going on. And a lot of it is, as Angela has said several times, on the clinical side. So even though the oversight goes into it and is definitely part of it, a lot of these decisions and service planning revolves around the clinical person in regards to the individual and their assessed service needs. So hopefully that should be helpful. And even if you can't make, we just sent these out to the AAA. So again, if somebody wants an invitation and no one at your AAA has it, feel free to, send me an email and I can forward you an invitation. But basically, we wanted these to be available so that you can look at it from both perspectives and get a well-rounded idea. So nothing exciting, but it will be more detailed and instructive. So thank you. Oh, Nita, I don't believe so. We have it set up as just like this as a Teams meeting. And from my understanding, there's no limit. Sometimes in webinars, you have a limit as far as how many actual people can phone in or email in, but I don't believe they do. So if the case managers want to see it, you can definitely disseminate it, or if they want to view it in a room or something, whatever they want to do. We want to make it accessible. So thank you. Thanks for all of your interest, and we really appreciate it. So we'll look forward to talking it out.
And then Linda asked, what notification will providers get for the new rates since there isn't going to be a contract addendum? We've discussed that internally. We haven't come up with a final process yet of how we're going to communicate that all to the providers, but we'll add that to the FAQ. We'll work on trying to finalize a process that will get notification out, or if maybe you guys just send the rate sheet out. So more to come on that. That hasn't been decided definitely right now. How will the average rates be handled? Barb, can you go into more detail about that?
Yes. Sorry, I have quite a cough going on here. There's a rule that says, I don't have it in front of me, so I don't know that I'll name them all, but homemaker, adult daycare, transportation, sorry, social work, counseling, and there's one more, I believe, have an average rate for each region. Is not in the rule. How will those be handled?
We'll look into that. We'll add that to the FAQ and we'll see if these rate changes are going to affect those average rates or if they'll stay the same. But thanks, Barb. I appreciate more information about that and we'll work on getting an answer out to everybody. Any other questions about anything that we talked about? We weren't sure if this was going to last a full hour and a half. So if there aren't any more questions, we can end a little bit early. Remember, if anything comes up, if you guys go back and you read the rule, you have additional questions, feel free to email the Provider Network Management mailbox. We'll add it to the FAQ. So if you guys go back, meet as a team, process it, read the rule, just get any questions over to us. Obviously, Alicia, Sarah, everybody, we're all very involved with all of these trainings. So we'll discuss it as a team. We'll make sure that we have standardized answers across both clinical and oversight. We've been meeting a lot internally to make sure that, like Alicia said, our trainings pretty much mirror each other. They're just coming from the oversight perspective and the clinical perspective. Kathy asked when the recording is going to be available. So if you guys haven't noticed, we've kind of worked on a new platform to make trainings more accessible to you guys. So we have to get this recording over to our communications team and then they put it on. It's a private YouTube channel that like you wouldn't be able to go search it, but you can access it by a link. So we'll get you guys the link. That's normally a pretty quick process. So I'm hoping to have that link by, I don't want to make any promises of today or tomorrow, but by at least this week. The slide deck obviously is ready to go. So we'll get that out to you guys timely. Let us know if you guys, since this is a new way of sharing trainings with you guys, if you guys ever have any problems accessing that YouTube link, just please let us know. And then Jessica had a last minute question. Are the clinical teams being trained to send both the care plan and the service plan to our providers? And say, Alicia, I saw you pop on.
Yeah. So, there's still a few outstanding questions on that. And so people still had some questions at one of the last site directors. So, yes, we can incorporate that, but it is something, again, that both pieces are considered the person-centered service plan. So, I'd like to remind everybody to focus on when you are documenting, you don't have to say that you're sending both items. You could say person-centered service plan sent to XYZ. So we want to make that easier for you. And once we do have some definitive answers on still just a few of those little pieces, I am planning to update the training that we did back in September so we can give, newer updated information, for instance, like talking about only trying to make the contact once and that sort of thing regarding providers. So remember, the main focus is on the providers, this information being sent to the provider. So, as far as clinical and as far as provider oversight, as long as the case managers are sending it out, if it never comes back, that's on the provider. I mean, obviously we will keep record of that, or you will keep record of that if it comes back and is signed, but it's not something as far as a super involved process that it has to be vetted when it comes back and the signatures need to be reviewed or anything of that nature. So I hope that that's making everybody maybe feel a little bit better as we're just kind of in this conversational type of situation. But we want to make this work for everybody and make it the least cumbersome as possible. So we can certainly talk about it during the clinical training, maybe at the end if people have questions or concerns after hearing both of these, and also Meredith's assisted living information tomorrow. So it's a week full of trainings, yay. But so, everybody can bring all their questions. And like Angela said, we're trying to bring them back and make sure everybody in all of our different areas is on board with our answers. So again, that's why we're trying to some of the questions we probably do know the answer, but we want to make sure that everybody's on board with that and that nothing has changed or another little component of a rule that maybe I might have missed that's in your area. So that's kind of why we're doing this. So thank you.
So Easter asked, is there any process in place to ensure that the rate increases get passed to the aides instead of solely staying in the pockets of the agency owners? No, I don't. We've kind of discussed that a little bit internally, but no, it's like we know that there's a rate increase, but we don't know what the providers are exactly going to do as far as increases to the direct aids. If you guys are hearing issues, from aides, I mean, I'm sure the case managers might hear it as well. If you guys are hearing issues from aides, providers, if providers are asking anything, feel free to email us. This is obviously a big change. A lot of rate increases are jumping significantly. So obviously the whole point of the rate increase, like Easter said, is for it to get to the aid, but we don't know what that's going to look like yet. Well, thank you guys. We don't take your time lightly, so thank you for giving us an hour today. If questions come up, feel free to pass them along. If you guys need any of the training links, feel free to shoot us an email. And let's see, we don't know when we're going to send out the rate increase email because we're waiting on that CMS approval. So we're told it's going to come sometime in December. So we're waiting on it. And then as soon as we get it, we're going to pass it along to you guys. That's when we're going to get you that updated notice and the rate sheet. We already kind of have them working. And once we get that final approval, we'll get them out to you guys. So you guys will know right after we know. Well, thank you guys. And I'm sure we might see some of you in trainings later on this week.